Hello, I'm Hannah Sachs, Editor-in-Chief of NEJM Evidence, and this is Stat.
One day, 66 million years ago, an asteroid struck what is now the Yucatan Peninsula. The catastrophic force of the impact set off a mass extinction event. It is thought that nearly 75% of the species on Earth perished, including most dinosaurs. But some dinosaurs survived. In fact, small-beaked dinosaurs gave rise to modern birds. Turns out, dinosaurs were a heterogeneous lot, and the small-beaked varieties were less susceptible to asteroid-induced extinction than their larger, unbeaked counterparts. Heterogeneity, it turns out, is not just of interest to paleontologists. Differences in the effectiveness of treatments across participants in a clinical trial, referred to as treatment effect heterogeneity, is vital to understanding how to apply the results of clinical trials to clinical practice. Imagine results from a randomized trial were just published, showing that, compared with placebo, a new drug lowers the rate of heart attacks. The result, a 30% reduction, describes the average effect of the new drug in a group of people, those who got the active treatment in the trial. That's a very different thing than the reduction in the risk of a heart attack for an individual participant. That's because, generally, in a trial, each person either receives the new therapy or doesn't, and either experiences the outcome or doesn't. Therefore, the reduction in risk for an individual participant is not observable in a clinical trial. In theory, randomization helps ensure that groups are balanced with respect to characteristics, both those that are known and those that may be unknown at the time of the trial, that might affect the magnitude of benefit or risk. But individuals in each arm will still differ from each other based on those characteristics. Sometimes treatment effects within subgroups of participants are estimated from the trial data. However, such subgroup estimates may be prone to both false positive and false negative results. False positives are likely because looking at many subgroups constitutes multiple testing and may lead to attributing positive results to the intervention that are actually due solely to chance. False negatives are also likely because subgroup analyses necessarily involve looking at smaller number of participants, meaning the analysis may be underpowered to detect a difference.
Imagine trying to study an asteroid strike's effect on Spinosaurus, a relatively small group within the much larger population of dinosaurs.
If the average benefit across groups is not always reflective of the individual benefit, and subgroup analyses are unreliable, how should you go about applying new results to the care of your patients? Well, let's look at some ways to estimate how well an average result applies to individuals with particular characteristics. First, consider the effect of baseline risk. If the new drug results in a 30% relative risk reduction, the absolute difference for a patient with a 1% risk of having a heart attack is 0.3 percentage points. But if a patient has a 20% risk of a heart attack, that same relative risk means a 6 percentage point drop in risk. The absolute size of the treatment benefit is important to consider when weighing trade-offs with adverse events. Say you were to build an asteroid shelter to house all dinosaurs. It might protect against extinction. But by housing all sheltered dinosaurs together, you might increase the chances of running into a hungry T-Rex, a likely fatal adverse event. Maybe that's a risk worth taking for a big, unbeaked, very asteroid-susceptible dinosaur, but definitely not for a small, beaked, relatively asteroid-resilient one. Of course, the utility of this type of analysis depends on how well you can model an individual's risk of an outcome. Another approach is to try and estimate what is sometimes called the conditional average treatment effect, which is a treatment effect for individuals with specific characteristics. In other words, the conditional average treatment effect is an estimate of how the difference in outcome between the treated and untreated case varies depending on these characteristics. Investigators develop a statistical model that incorporates treatment and identified baseline characteristics, say size and presence of beak, or age and smoking status. Importantly, the set of baseline characteristics incorporated into the model may be identified in the data and not known ahead of time. This is increasingly accomplished with machine learning techniques. The conditional average treatment effect can account for more than one patient characteristic at a time. This approach, however, can be subject to a number of limitations, such as the problem of multiple testing. It is also possible that the trial dataset is not large enough to reliably choose among multiple candidate sets of patient characteristics to include in the model, a situation which is described as the model being underdetermined. Now that you understand heterogeneity of treatment effect, you're prepared to more rigorously consider how the results of a trial apply to your patients. Moreover, if called upon to design an asteroid shelter for dinosaurs, you will know which species are most important to get under shelter. Just don't bring in the T-Rex.